Welcome back to CE Solutions. My name is Caleb Frady, and this is Volume 2 of the Essentials of Neonatal Resuscitation. I have a Bachelor's of Emergency Medical Science, a Level 2 North Carolina paramedic instructor, National Registry paramedic, and I currently serve as a full-time EMS educator and part-time in a rural county in North Carolina. Today's objectives for the Essentials of Neonatal Resuscitation Volume 2. We will recognize the need for advanced airway management in neonate patients, illustrate the neonatal intubation process, describe vascular access and ALS medications utilized during neonatal resuscitation, review the pathophysiology and management for conditions specific to newborn patients. To determine the indications and when it's appropriate to move forward with advanced neonatal airway management, we should look at our resuscitation algorithm, as it's going to help guide us through BLS maneuvers that as ALS providers we should absolutely do first, and when it's necessary for us to upgrade the level of care to more advanced interventions such as intubation. Advanced airway management of a neonatal patient is located towards the bottom of our assessment algorithm, and according to this, we should consider advanced airway management such as intubation if the newborn's heart rate remains below 60 beats per minute despite effective BVM ventilations and chest compressions. So those may be some of the indications for us to proceed forward with intubation, along with prolonged positive pressure ventilation. So if we've been performing CPR and ventilations for an extended period of time on a newborn, it may be indicated to advance the airway that way, as BVM ventilations can lead to gastric distension and cause vomiting. If we notice meconium stained fluid, that we'll talk about a little more in depth and later in the lesson, but meconium stained fluid in a non-vigorous newborn can be an indication for intubation. And other facial abnormalities that may make BVM ventilations very difficult, such as cleft palate or what you see on the screen, which is called Pierre-Robin sequence. And that's where the patient's chin is small and it's posteriorly placed. So one, the tongue can be a very common obstruction, but it also makes it difficult for us to get a mask seal when the patient's chin is recessed back, like you see in Pierre-Robin sequence. Neonatal intubation is a low frequency and a high acuity skill. And to be successful, it depends on several factors, such as the performer's skill level, the equipment available to the provider, certain patient characteristics like a difficult airway or trauma, and system characteristics, such as continuing education and support in performing this type of procedure. Mockery looked at first pass success rates with neonatal intubation, and they found that neonatal physicians had a 60% first pass success rate, whereas fellows had a 53% success rate, and resident physicians had a 23% first pass success rate. This should illustrate for us that even high level providers still struggle with this skill in a more controlled hospital setting. Mockery also gives us points and reports that the most common adverse effect noted during those intubation attempts was acute desaturation. He found that occurred 51% of the time. And more adverse events were noted with increased intubation urgency and multiple attempts. That should challenge us that rushing through this type of procedure will harm a neonatal patient, and not being proficient and competent in it to begin with will also harm a neonatal patient more than it will do any good. Supraglottic airways can serve as a quick and easier intervention than performing neonatal intubation. And Yamada et al. Found that supraglottic airways are able to provide better ventilations than BVM ventilations alone, and also were found to reduce the need for intubation. Now, the caveat to this is it oftentimes depends on local protocols and equipment that the system carries in terms of whether intubation or a supraglottic airway is most indicated. The other disadvantage is that with your supraglottic airways, there can be limited sizing options available for preterm newborns. As we discussed in Volume 1, about 43% of pre-hospital deliveries are preterm deliveries. So some of those supraglottic airways may just simply be too big for our neonatal patients, which is where neonatal intubation has the advantage. I want to take a few minutes and discuss the anatomical considerations for newborn airway management. The first one includes a proportionally larger head compared to the body. So the larger head causes neck flexion, which closes the airway off when lying supine. And in emergency or urgent settings, that's commonly found in the pre-hospital environment, airway positioning is often overlooked or suboptimal. So ensure that we're positioning the airway appropriately. Your newborn patients are going to be preferential nose breathers. So if there's an occlusion in their nares that can cause respiratory distress, the reason they're preferential nose breathers is because oftentimes immediately after birth, they begin to feed. So breathing through their nose allows them to breathe while they're also feeding, whether that's breastfeeding or formula later on. The tongue is larger compared to the oral cavity, and this just means that it's going to take up more space in the back of the oral cavity itself or the airway, and it can be exacerbated by genetic conditions such as a baby born with Down syndrome or Pierre-Robin syndrome that we showed you earlier. The arytenoid cartilage in a neonatal patient is longer compared to the size of the airway, and that can make identifying and finding the glottic opening more difficult. The larynx is anterior and sits closer tucked underneath the larger tongue, again making it more difficult to visualize the glottic opening. The epiglottis is shaped differently. It's longer, narrow, and less flexible, and you may see it referred to in some texts as being omega shaped. And lastly, the narrowest point of the newborn's airway is just below the glottic opening. This can make it difficult to pass an ET tube and can make an obstruction at that level more difficult to clear. Performing a difficult airway assessment is a critical step in the neonatal intubation process. You should look for facial abnormalities such as facial asymmetry or genetic conditions such as cleft palate. Assess for mouth opening and tongue size, looking for any abnormalities that may complicate the intubation process. Check the neck position. This includes having the airway aligned in sniffing position, or if there's trauma involved, understanding that that is going to complicate the intubation process. A preterm newborn has a higher morbidity from advanced airway management and can complicate the process. Difficulty with bag valve mask ventilations can be a result of a poor mask seal or an issue of an obstruction. So before intubating, ensure that the airway is clear and that you're able to ventilate with a mask seal. So if the intubation fails, you're able to fall back onto bag valve mask ventilations. The difficult airway assessment in a newborn patient can impact the equipment and size of equipment that you utilize, the technique or intervention that you utilize, such as electing to not intubate and maintain bag valve mask ventilations with rapid transport. It can also affect the operator that's chosen to perform the procedure. It's not always based on the years of experience, but based off the experience with that patient population. So if you have a provider that has intubated neonatal patients before, that may be the best provider to utilize in a neonate with a difficult airway based on assessment.
The general approach to intubation really begins by gathering all of the equipment that you may need to successfully intubate a neonatal patient. That would include suction catheters, sizes 5 French up to 10 French, ensuring that you have the suction unit set to the lowest possible pressure that's needed, likely around 100 millimeters of mercury. Miller blades. Your Miller ET blades are going to be more effective with intubating a pediatric patient due to their anatomy. And we'll discuss that a little bit more as we get into the actual procedure of intubation. Adhesive tape to secure the tube, and your endotracheal tubes. So, Daria et al. In 2022 concluded that there's a lack of evidence for or against cuffed tubes, and that cuffed tube neonates were less likely to need tube replacement for any reason. So, really, what that means for us as providers is that uncuffed or cuffed tubes, there's really no definitive evidence for or against either one. So, utilize what you have available and have additional sizes should you encounter any difficulties. When selecting your ET tubes, you'll need sizes 2.5 to 4. If your newborn is before 28 weeks, utilize a 2.5 size ET tube, and if the newborn is born after 35 weeks, utilize a 4.0 ET tube. After your equipment has been gathered, we should then plan and prepare our approach. This would include selecting who is going to be the person intubating the neonate, performing an airway assessment, accomplishing appropriate airway positioning, and ensuring that all providers understand what to do if the first attempt is unsuccessful. And lastly, here, keep in mind that during the intubation attempt, if at any point it's unsuccessful or the neonate develops bradycardia as a result of the intubation attempt, discontinue the attempt and ventilate the patient with a bag valve mask. The technique of neonatal intubation is very similar to that of any other patient. Begin by holding the ET handle in your left hand. If available, utilize a pediatric handle. And use your right hand to open the newborn's mouth so you can insert the blade. As you gently insert the blade, your goal here is to sweep the tongue to the left as you advance the blade midline towards the glottic opening. You should identify the airway anatomy as you go. Ideally, you want to identify all of the airway structures around the glottic opening so you're 100% positive of where the ET tube is being placed. In an urgent intubation, it's very easy for us to insert the blade too deep and be unable to identify any anatomy because we've inserted the blade so deep that we're really just looking at the posterior oropharynx or down into the esophagus. And it's hard for us to identify where the glottic opening is. Oftentimes, in those cases, that can be a complication that causes a provider to hastily insert the ET tube into the esophagus, and we have an esophageal intubation because of that. If you do insert the ET tube blade too far down on your first attempt, slowly withdraw the blade back and begin identifying structures retrospectively. An assistant who's helping you can feel the neck around the level of the cricothyroid membrane and can help tell you if the blade is in too far, as they'll be able to feel that with their fingers, the blade being too far down in the throat. Once you've started to identify your structures as you're moving down the tongue, you're going to utilize the same motion, a forward and upward motion of the handle, to be able to visualize the glottic opening. Avoid rocking back on the lips, as this would cause trauma to the lips and can also make your view of the glottic opening worse. We typically are going to use a Miller blade in neonatal and pediatric intubations because the way their anatomy is set up, it's easier to use the Miller blade and move the epiglottis out of the way. The epiglottis in neonatal patients is a little bit larger compared to their airway, and it's also more floppy. So the Miller blade really helps move the epiglottis out of the way so we can see the glottic opening. If you're having difficulty exposing the vocal cords, you can use your left little finger to apply gentle cricord pressure to bring the cords into view, or if you have an assistant, they can also provide that cricord pressure to help achieve a better view. Only suction when secretions are noted, so don't do any routine suctioning to clear the airway before your attempt, only if you see anything inside the airway. And a practical tip of how to hold the ET tube as you're placing it is hold the ET tube higher up towards the BVM adapter. That's going to give you actually more fine control over the distal end to be able to direct that towards the trachea. The image you see here is just a practical tip to help with inserting the tube. Our neonatal patients are going to have, smaller mouths with larger tongues, and there's not a lot of real estate for the blade and the ET tube to pass for us to be able to insert the tube while still maintaining our view, which we know is kind of a golden principle of intubation, is you have to visualize the ET tube passing into the trachea. So performing a lip lift where you just take one finger from your right hand, or an assistant can do this for you, and lifting the right lip up gives you more space in the upper airway there to insert the ET tube. Once you've inserted the ET tube through the glottic opening, make sure you only insert it deep enough to where the black line passes the glottic opening. Oftentimes, we can insert these tubes too deep because the airway structures are just smaller and shorter. So when you do confirm your intubation, ensure you have equal chest rise and fall, good capnography, and negative epigastric sounds. This would be the view that ideally you would want to see. Now, in the image you see here on your screen, they're using a curved video laryngoscopy. If you have that ability at your service, video laryngoscopy is absolutely a method of intubation that can increase your success if done correctly. Um, but with any intubation, it's extremely important, and it increases our chances of success if we're able to identify all of the anatomy. You can see very clearly here in this neonatal intubation that the epiglottis is more omega shaped compared to an adult epiglottis. We can see the vocal cords seem to be more anterior, and you can see the arytenoid cartilage is just below. So when you're able to identify all of this anatomy, you are 100% sure when you pass the ET tube where it's going. And that can increase your chances of first pass success just by identifying and being familiar with airway anatomy. Like we talked about, after the tube is passed, secure it to the side of the mouth and the cheek in your newborn, and then confirm placement. That's what your adhesive tape is for. Make sure that you're getting an end-tidal CO2, negative epigastric sounds, equal lung sounds. You may or may not see tube condensation. That's not an extremely reliable indicator, but it is something that is commonly seen post-intubation to confirm placement. And then proceed forward with providing your ventilations at 40 to 60 times per minute, and consider placing an OG tube. This will be utilized if you've performed BVM ventilations for an extended period of time and there's gastric distension, or if you suspect a diaphragmatic hernia. We'll discuss this a little bit later, but clinically, we would suspect this if the newborn has decreased lung sounds on the left side. In about 80 to 90% of cases, the hernia is on the left side, has a concave abdomen. That's because the abdominal organs have protruded up into the chest, and has an increased work of breathing. IO access can be used in all age groups, and in a newborn patient requiring resuscitation, this can provide rapid access for us to administer IV fluids and medications that are indicated. Many of our IO needles, however, are not indicated for patients less than 3 kilograms. So in the case where you have a premature newborn less than 3 kilograms, you may need to contact medical direction for advice. You can see here on the image on your screen, the pink top, which is the 15 millimeter 15 gauge needle, is rated for infants that are newborns that are 3 to 39 kilograms, and is what you would use in a neonatal resuscitation. The biggest consideration here with IO needle sizes and types of IOs is for you to be familiar with the style and brand that your service carries, so that when you do have to utilize that procedure in the field, you're able to do so efficiently. It's also important for us to understand the appropriate IO access sites. So the proximal tibia is the preferred site in neonates, and it can easily be found by measuring one finger beneath the tibial tuberosity and then moving slightly medial to that line. That puts you on a flat aspect of the tibia. With the distal femur, you're going to secure the leg straight, and you're going to measure 1 centimeter above the patella, and then move about 1 centimeter medial to that line. A third option is the distal tibia if for some reason you're unable to use the proximal tibia and the distal femur. IV access is also an option in neonatal resuscitation. This can, however, be a difficult procedure and oftentimes time-consuming during a resuscitation. However, if someone on your team is experienced in obtaining neonatal IV access, allow that person to try, especially if you need the access and for some reason IO is difficult. When doing IV access on a neonatal patient, you're likely going to need to use the smallest catheter size you have available, which would be a 24 gauge or yellow IV needle, and appropriate PRN adapters and equipment to attach to that.
In neonatal resuscitation, there are very few medications that a paramedic may need to administer, as airway management and chest compressions are priorities in this patient population. However, there are some cases where medications may be indicated. Epinephrine is the first one I want to discuss. It's indicated when a newborn has a heart rate that's less than 60 and is unresponsive to ventilations and chest compressions. The dose of epinephrine is 0.01 milligrams per kilogram IVIO. If administering it through the ET tube route, you need to double the dose and it becomes 0.1 milligrams per kilogram when given through the ET tube. Most term neonates weigh about 3 to 4 kilograms, which will put the drug dose of epinephrine IVIO at 0.04 milligrams. And the average weight of a newborn that's born before 28 weeks is 1 kilogram, which would put your drug dose at 0.01 milligram. So, accounting for the gestational period and when the baby was delivered will affect your estimation of their weight. Fluid resuscitation is not a priority in neonatal care, and so it's not routinely needed. But if you do suspect hypovolemia, normal saline can be administered at 10 milliliters per kilogram. We must be very careful not to fluid overload the patient. So utilize a drip chamber if it's available. IV syringes with specific amounts of fluid in them work well to deliver the appropriate amount of fluid without overloading the neonatal patient. In cases of hypoglycemia, dextrose is indicated when the blood sugar in a neonatal patient is less than 45 milligrams per deciliter. If the blood sugar is less than 45 and you see other signs of hypoglycemia in neonates, such as jitteriness, irritability, apnea, floppiness, tachycardia, seizures, and lethargy, those may be indicators for the need of dextrose containing medications. After birth, a healthy newborn's blood sugar starts at about 30, and then over the first 12 hours of life, it increases to a normal range of 45. A standard dose for dextrose is 2 milliliters per kilogram of dextrose 10%. A pneumothorax in a neonatal patient can occur after birth if meconium is inhaled by the newborn, if they have a weakened area from infection or poor development, such as a preterm infant with less developed lungs, or from aggressive positive pressure ventilation by providers. Some of the signs of a pneumothorax in a neonate include significant respiratory distress that doesn't improve with ventilations, and unilateral and decreased breath sounds are noted. When a significant pneumothorax is affecting a newborn's hemodynamics, a needle decompression may be indicated depending on local protocols and equipment available to you. To perform this procedure, use a 22 gauge IV catheter. Insert that through the second intercostal space just above the second rib. Remove the introducer needle and attach it to an IV extension set. At the end of that extension set, place a three-way stopcock and a 20 milliliter syringe. A 10 milliliter syringe would work also. Open the stopcock to withdraw air from the pleural space, and once the air is withdrawn, close the stopcock and disconnect your syringe and secure the tubing. Continue monitoring for the redevelopment of a pneumothorax. If it does redevelop, you would just simply need to reattach the syringe, open up the three-way stopcock, withdraw air from the pleural space once again. A pneumothorax is also something that is going to require rapid transport to the hospital when it's suspected. Meconium, which is a newborn's first bowel movement, normally occurs outside of the womb. In a small number of newborns, this occurs inside the womb or during delivery, and that meconium fluid can obstruct the airway. This occurs about 10 to 15% of deliveries. The passage of this meconium, like I said, can occur either before or during delivery, and it's more common in post-term newborns. So, an extended gestational age, such as a 42 or 43-week pregnancy, has a higher likelihood of presenting with meconium stained fluid and affecting the newborn patient. Inhaling this meconium, because it's a very thick, dark green bowel movement, inhaling this can obstruct the airways and lead to hypoxia, atelectasis, which is alveolar collapse, delayed transition to extrauterine life, and aspiration pneumonia. The most current recommendations for managing a patient with meconium stained fluid is that if the newborn is crying and vigorous, so in other words, we're progressing down our neonatal resuscitation algorithm and our baby is responding well to dry, warm stimulation and other routine care, then no further treatment is needed, and continue to monitor and assess the airway according to that algorithm as you provide transport to the hospital. So no suction in that case would be needed. For a newborn who does not respond well to that routine care and treatment is continuing, notify the hospital early and provide rapid transport. It is acceptable to suction any obvious secretions from the newborn's nose and mouth to clear the airway, but tracheal suctioning is no longer routinely recommended in neonatal care. And the reason for this recommendation is because it comes from a point of view of doing no further harm and prioritizing, in this case, intubation and tracheal suctioning can delay more appropriate interventions such as providing warmth, positive pressure ventilations, and rapid transport to the hospital. A diaphragmatic hernia is a very serious complication noted on delivery of a newborn. It's when there's an opening in the diaphragm that causes the abdominal contents to enter into the thoracic cavity. This can lead to severe respiratory distress and hypoxia, depending on the size and location of the hernia. 85% of diaphragmatic hernias are on the left side, and the diagnosis is often made right after birth. Ultimately, surgical repair is needed to repair this condition. And if we note this after delivery, we should continually reassess for the development of a pneumothorax and resuscitate with supplemental oxygen. So, like we discussed in volume one, we target our SpO2 and initially begin BVM ventilations with room air oxygen at 21%. And we do that throughout the first few minutes of working the neonatal resuscitation, as 100% oxygen in this patient population has been proven to be harmful. So, in a diaphragmatic hernia, however, that's kind of the exception to the rule. If we suspect the diaphragmatic hernia, we should begin our resuscitation with 100% supplemental oxygen attached to the background mask.
A seizure is never considered normal, as it represents a neurological condition such as hypoglycemia or other electrolyte disturbance. They can be caused by developmental defects, drug withdrawals after birth, encephalopathy, epileptic seizures, and intracranial hemorrhage, to name a few. The incidence in neonatal seizures can be fairly high. The information I have here from Mija et al. Reports that it can be as high as 57.5 cases per 1,000 infants who are less than 3 pounds at birth. It's also important for us to distinguish between normal motor activity and seizure activity. And what I mean by normal motor activity is simple jitteriness. This would be the newborn is having tremors. However, the key here is the tremors can stop with gentle pressure on the limb. The tremors may also be triggered by some sort of external stimulus. So if you notice some sort of jitteriness or tremor of an arm or a leg, a good assessment to perform is to see if you can place a hand on that extremity. And if it stops the tremor, then it's likely just normal motor activity as a response to a stimulus. Seizures, however, often include some sort of deviation or fixation of the eyes and clonic jerking movements. Now, there's different types of seizures that can present in neonatal patients. Just to name a few, a subtle seizure would be something considered where you're seeing subtle signs such as eye blinking, rowing or pedaling of the legs, and repetitive lip smacking. Clonic activity is a little bit abnormal compared to what you would see in an adult patient. Because the newborn's nervous system is immature, we typically don't see bilateral clonic movements. We typically are going to see unilateral jerking or kicking of one extremity. And then our tonic presentation for a newborn seizure is persistent posturing. Respiratory depression secondary to opioids. The signs and symptoms of this typically present themselves about 24 to 72 hours after birth, and the symptoms are often a reflection of the half life of the involved substance, such as heroin, which has a general half life of 24 hours. The symptoms of this condition would include central nervous system irritability, so that could present with tremors, a high pitched cry, decreased sleep, and seizures. We may also note autonomic dysfunction with fever, sweating, and tachycardia, GI problems such as feeding difficulties and loose stools. The management for these patients is to provide ventilation support and transport. We should avoid administering Narcan to neonatal patients that we suspect have respiratory depression secondary to opioids, as that can precipitate seizures and is currently not recommended.
Vomiting can be normal and occasionally blood streaked in the first few hours of a newborn's life. And within the first 30 days, vomiting can have several different causes, some of which are benign and normal, others of which are concerning. Persistent vomiting that is dark red suggests GI bleeding in the gut, or bilious vomiting can suggest either some sort of GI obstruction or increased intracranial pressure. The management of vomiting involves protecting the airway from aspiration, and several different causes can cause vomiting in a neonatal patient, such as esophageal atresia, which is where the esophagus doesn't fully form. Presents with a newborn that's drooling and frothing at the mouth. They may choke when they try to feed because the milk comes right back up because the esophagus is malformed. Another cause is infantile hypertrophic pyloric stenosis. So the pyloric muscle thickens, leading to obstruction of gastric outflow. This usually presents around 3 weeks and presents as the stomach muscle tries to forcefully contract to overcome the obstruction of gastric outflow. This leads to projectile vomiting. Blood can be found in the vomit from gastritis or a Mallory Weiss tear, which is where it tears at the junction of the esophagus and the stomach. It can also be an intestinal malformation, otherwise called twisted intestines. This occurs during development at the fourth and 12th week. And the vomit can have a fecal odor to it and is bile stained. Surgery would be needed to correct this condition if it's present. Intestinal atresia and stenosis, so parts of the bowel do not develop, can lead to vomiting. Vomiting can also occur with other conditions, such as hydrocephalus, meningitis, and withdrawal symptoms. Um, Meningitis and hydrocephalus, along with trauma, can lead to increased intracranial pressure, leading to vomiting from that mechanism. Diarrhea in a newborn patient can also be a benign finding. The biggest complication is that diarrhea can lead to rapid dehydration and electrolyte imbalances in a newborn patient. The management of diarrhea generally involves estimating the degree of dehydration and the administration of IV fluids if necessary. Some predictors of dehydration in a newborn patient include just an overall poor general appearance and activity, poor vital signs such as an elevated heart rate outside normal ranges, rapid respirations, delayed capillary refill, dry mucous membranes, unexplained and abnormal weight loss throughout the first 30 days of life, sunken in eyes, a depressed fontanelle on the top of the newborn's head, and low urine output. And again, the newborn is suffering from diarrhea in their stools. So a newborn should produce a bowel movement about 5 to 6 times per day, or after each feeding.
Issues of thermoregulation. A fever in a newborn is characterized by a rectal temperature that's greater than 100.4 degrees. Rectal temperature is going to be the most accurate method to assess a temperature in a newborn patient. Fevers can be caused in newborns through infections that they may pick up within the first few days of life, but also overheating, where you may have parents that overbundle the newborn and maybe go too far to keep the newborn warm, and that results in the core temperature elevating. Anytime you suspect or identify a fever in a newborn, begin looking for any rashes or abnormal activity, and take note of any increased respiratory effort, as those can be clues to the status of the newborn and help guide some of your resuscitation from there. Hypothermia in newborns is a body temperature that's less than 95 degrees Fahrenheit. And the biggest consideration with hypothermia is that newborns are very sensitive to environmental conditions. So if they're not wearing the appropriate layers of clothing, or their skin's exposed to the environment, they can lose heat very quickly and become hypothermic.
Congenital heart conditions are the most common birth defect. It occurs about 8 of every 1,000 births, and one-fourth of those are considered critical, meaning they're associated with hypoxia and require some sort of intervention within the first month of life. Pulse oximetry is a valuable assessment tool for pre-hospital providers to have an index of suspicion of congenital heart disease post-birth. If we measure the SpO2 on the right hand and 1 foot, what we'd be looking for is an SpO2 that's less than 95% or 3% difference between the two. And that's an indicator of hypoxia that's associated with congenital heart conditions 24 hours after delivery. Our field priorities for managing newborns with congenital heart condition is prompt recognition and transport to appropriate facilities who we suspect have a congenital heart condition. There's two main categories of these conditions: non-cyanotic disease and cyanotic disease. We're going to take a few moments and go through each of those specific diseases within those categories. Beginning with non-cyanotic diseases. An atrial septal defect is caused by a failure of the foramen oval to close, allowing oxygenated blood to flow into the right atrium from the left atrium. This can cause atrial enlargement and lead to pulmonary hypertension. It can lead to atrial arrhythmias, failure of the newborn to thrive, frequent infections, and even heart failure. Now, small atrial septal defects typically close on their own. Large ones, however, may need surgical repair. The next non-cyanotic disease would be a ventricular septal defect, which is where an opening in the septum allows oxygenated blood to flow from the left ventricle into the right ventricle. This decreases stroke volume, so there's less blood being ejected from the heart, and puts the right ventricle under greater pressure, which leads to increased pulmonary hypertension. Now, larger openings present with delayed growth, exercise intolerance, and pulmonary infections. Signs of heart failure in this category would include tachyarrhythmias, grunting, tachycardia, fatigue with feeding, and diaphoresis. The next non-cyanotic disease is a patent ductus arteriosus. This is where the ductus arteriosus fails to close after birth. Normally, it closes within a few hours. In this condition, what happens is oxygenated blood is shunted from the aorta across the duct to the pulmonary artery, where it then mixes with deoxygenated blood. This is going to lead to an increased workload of the left side of the heart and less blood being delivered to the lungs for gas exchange. It's going to present with fatigue, failure to thrive, poor feeding, bounding peripheral pulses, and increased work of breathing. Coartication of the aorta. This is narrowing of the aorta just beyond where it branches and goes to the head and the arms. So what that causes is the left ventricle to have to work harder to pump against the increased resistance due to the narrowing of the aorta. This is going to lead to an increase in blood pressure to the head and the arms and less blood flow to the legs. Presents as heart failure in neonatal patients. This presents as heart failure. Many patients can remain asymptomatic until later in childhood, and surgical repair is typically performed before 2 years of age. Our cyanotic diseases are classified in this category because this is where deoxygenated blood mixes with oxygenated blood, and then that blood is then pumped to the body tissues. It would be called a right to left shunt. That would include conditions such as pulmonary stenosis, where there's a damaged pulmonary valve causing decreased blood flow to the lungs, would present with jugular venous distension, right ventricular hypertrophy, and cyanosis. A truncus arteriosus is where the pulmonary artery and the aorta are combined into one vessel. This would cause heart failure. Tricuspid atresia is where the patient lacks the tricuspid valve. This would result in an undersized right ventricle, limiting the amount of blood pumped into the lungs, would lead to severe hypoxemia and death. Treatment would require rerouting the inferior vena cava and the hepatic vein to pulmonary circulation. So that would be something that would need to be performed in a surgery setting. Hypoplastic left heart syndrome is where you have complete underdevelopment of the left heart, making it unable to meet the body's needs. In this case, a heart transplant is necessary. Tetralogy of Fallot is a combination of ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. With tetralogy of Fallot, the ventral septal defect causes oxygenated blood to flow from left to right. Pulmonary stenosis puts more strain and pressure on the right side of the heart, making it work harder. Right ventricular hypertrophy is a result of the pulmonary stenosis because of that increased right-sided demand. And these defects all result in poor oxygenation. Cyanosis in tetralogy of Fallot occurs in the first few hours of life as the ductus arteriosus closes. A TET spell is what we would refer to when the oxygen saturation in one of these newborns suddenly decreases. So usually it's from some sort of sudden pulmonary outflow constriction and would present with hypoxia, irritability, rapid and deep breathing that if it's untreated will progress to seizures, syncope, and death. Care for a patient in a TET spell would include trying to keep the infant calm, holding a knee to chest position. What this does is it increases the left to right shunting, helping more blood enter into pulmonary circulation, which can alleviate some of the hypoxia. Transposition of the great arteries would occur when the pulmonary artery is connected to the left ventricle and the aorta is connected to the right ventricle. So they're reversed. A newborn can only survive from this defect if another defect allows for the mixing of blood. So if there's a ventricular septal defect or a patent ductus arteriosus that allows mixing of the blood and essentially buys the newborn a little bit of time until surgical repair can be completed. Total anomalous pulmonary venous return. This is where 4 pulmonary veins do not return to the left ventricle and attach to the right atrium. This would result in pulmonary over-circulation and presents with severe right heart strain. Now, there's many congenital heart conditions such as this for providers to know about and understand. And the management for patients with congenital heart conditions is prompt recognition and rapid transport. Provide neonatal resuscitation with oxygen, CPR if needed, and emphasize transportation to an appropriate facility that can handle this high level of patient care.